This meeting is being recorded.
A very good evening to one and all. Welcome back to the today's session. Today we have our guest speaker, Dr. Suvarna Rajesh Kale ma'am. We welcome you, ma'am. We welcome you all the participants. So today ma'am's topic will be abortion and its repertorial approach. So coming on to the madam's introduction, ma'am is a associate professor from OBG department from Srimati KB Abadat College, Chandwad. We welcome you, ma'am. We welcome you, all the participants. Over to you, ma'am. Yes, ma'am.
Okay. Should I start, madam, now? Hello? Should I start?
Yes, ma'am. Kindly. Yes, ma'am.
Now, I
Yes,
would
ma'am.
like to thank the organizer of All India Homeopathic Students and Youth Association. That is Dr. Lavanya, madam, who is the National General Secretary of the association. I would like to thank the National Vice President, Namita, madam, and I would like to thank our organizing secretary, Dr. Parikh, madam. So, very much thankful to all of you for giving me an opportunity to conduct a lecture on abortion and its repertorial approach. Now, first of all, I would like to say abortion is the most common condition which is commonly seen in day-to-day life. It is said that the fetal loss in early pregnancy is mostly due to abortion. So, vaginal bleeding in early pregnancy is always cause of the concern in any of the pregnant female. Now, we know abortion is as it occurs in mostly in early pregnancy. There are other causes of bleeding per vagina which is seen in early pregnancy. For example, it could be possible in ectopic pregnancy, or it is commonly seen in the vesicular mole, or what we say is hydatiform mole. So these are the three important factors due to which the female may have bleeding that is related with pregnancy: abortion, ectopic, or vesicular mole. And if you go to the causes which are not related with pregnancy, it could be because of cervical lesion, which may be in the form of polyp or varicosity of the vulva or CA cervix, or it may be cervical erosion. So these are the other causes due to which the female may have an pervaginal bleeding. So on many occasions, no certain cause of the early bleeding can be found. This can be very rarely seen. So it occurs mostly, if it occurs after 7 months, it is said to be an premature birth. Now we say the women are likely to miscarry at any period of the pregnancy, but most frequently it is mostly occurring during the third or beginning of the fourth month. When it takes place before or about this period, it is not very dangerous. Though repeated miscarriages or repeated abortion may cause profuse discharge, which may usually accompanied with an ill effect on the health of the female, which may impair the constitution, and very often it may lead to a chronic trouble in a female, which may be for lifelong. So here in short, I want to say the female who have miscarried once are exceedingly liable to had its recurrence, which liability is greatly increased if it has occurred 2 to 3 times. Okay, so this is most commonly seen in the females, which can be labeled that the females are having a repeated abortions. Now we want to see what are the positive factors, or what is the etiology behind the abortion, why abortion occurs. The causes are, it could be because of the genetic factor, it could be because of endocrine or metabolic factors, it could be because of the anatomic factors, infections, immunological factors, it may be thrombophilias. Some of the environmental factors are also going to be contributing for it, or other factors which are sometimes unknown to us. So these are some of the factors or etiological factors due to which the abortion may occur. Now, one by one, we are going to see in short each of the factors. The first is the genetic factor. So we say in majority 50% of the abortion or miscarriages are due to chromosomal abnormality in the conceptus, that is in the product of conception. Among this, we say the autosomal trisomy is very common, which contribute 50%, which is nothing but we say it is a cytogenic abnormality. So among the trisomy of every chromosome which has been reported, it has been found that most common trisomy is trisomy 16, which is found to be 30%. Similarly, if you see the polypody, which has been observed in 22% of the abortus, Now, what is this polypody? It refers to the presence of 3 or more multiple haploid number of chromosomes. We know the number of chromosomes mostly is 20, 22. There are autosomes and 2 are the sex chromosomes. So here this haploid number of chromosomes may be in 3n, which may lead to 69, or it may be 4n, which may lead to 92. So trisomy, or we say that triploidy is more common than tetraploidy. Tetraploidy is nothing 4. So it may be trisomy or it may be tetraploidy. Now the other chromosome abnormalities may be like mosaic, or it may be double trisomy, etc. may be found in very rare, that may be about in 4% of the abortus. Now here these genetic factors are very rare to be investigated, because many of us, they don't go for all these investigations. But it has been believed that this could be the one of the causes due to which the female may undergo abortion. Now, next factor what we see is the endocrine or metabolic factors, which contribute about 10 to 15% in the cases of abortion. In that, we say the luteal phase defect, that is called as LPD, results in early miscarriages, in which we see the implantation, or we can say the placentation process, are not supposed, or they are not supposed adequately. Now we know during the implantation there is invasion, adhesion processes. So these are not going to occur in a proper way because of the luteal phase defect. Next, there could be because of the deficient progesterone secretion. Now, we know the progesterone secretion in early weeks of pregnancy is through the corpus luteum before the placenta is being formed. So this deficient corpus luteum function leads to poor endometrial response to the progesterone, and which could cause an abortion in a female. Next cause is thyroid abnormalities. Now in thyroid abnormalities, which is found very commonly in the female, may be overweight hypothyroidism, or it may be hyperthyroidism, which are mostly associated with increased fetal loss. So here next factor regarding the thyroid could be, there could be autoantibodies which are often increased, which are found during, when we say about the thyroid abnormalities. Next causes regarding the endometrial or metabolic factor is, we see that diabetes. If there is an uncontrolled diabetes, it may has an increased reason of miscarriages. So it is, these are the one of the these are the factors which are contributing for endocrine or metabolic factors. Next factor is the immunological disorder. Now in immunological disorders, it contributes again about 5 to 10%. Here we say the first factor could be antiphospholipid antibody syndrome, which is called as PAS. Next factor is the immune factor, where the cytokines are immune molecules. So we see that the cytokines response may be either, it may be T helper 1 or it may be T helper 2. Now T helper 1 response is the production of the pro-inflammatory cytokines. So this T helper 1 is responsible for pro-inflammatory cytokines, which may be in the form of interleukin-2, interferon, or it may be tumor necrosis factor. So these are the 3 types which is found in the T helper 1. Now when we talk about T helper 2, the response is the production of the anti-inflammatory cytokines. Here that there are 2, that is interleukin-4, 6 and 10. So this is the difference between the T1 and T2. Now we see that if there is a successful pregnancy, it results predominantly from the T helper 2 cytokine response. But if a female with a recurrent miscarriage, she has more of T1 helper. Okay, so this is the difference if there is a successful of the female or successful pregnancy, or the female undergoes a recurrent miscarriage. Next, autoimmune disorder could be because of the human leukocyte antigen, which is called as LA, where there is incompatibility between the couples. So it leads to an formation of antibodies, and this can be one of the reasons to cause abortion in the female. The next factor is anatomical abnormalities. We say these anatomical abnormalities again contribute to around 3 to 38% in the cases of abortion. In that, we say the most common factor could be cervicouterine factor. Now, in cervicouterine factor, we see the most commonest factor is the cervical incompetence. We know cervix act as a sphincter, okay, which helps in remaining the os, which are the internal and external os of the cervix, are closed throughout the pregnancy. So if this cervical os are not competent enough to act as a sphincter, we say the condition called as cervical incompetence, due to which the female mostly goes to mid-trimester abortion. Second cause of cervicouterine factor could be congenital malformation of the uterus. We know the uterus is formed from the fusion of two Mullerian ducts. So if there is loss of fusion of this Mullerian ducts, it may give rise to bicornuate septate uterus, which may be responsible for again mid-trimester recurrent abortion, which can be only diagnosed when the female is advised to go for USG. Next causes of fetal loss could be here, because of these abnormalities, there could be an reduced intrauterine volume, reduced expansibility property of the uterus. We know the uterus is highly muscular organ, so it expands to its maximum extent. Because of this abnormality, it fails to get expand or reduces the expandability property. Next, increased intrauterine irritability and contractibility is one of the cause of the fetal loss. Next factor in anatomical abnormality could be uterine fibroid. There could be multiple fibroid at any wall of the uterus, okay, or there could be an intrauterine adhesion. This is also one of the factors due to which the female may undergo repeated abortions. Now, 5% of the abortions could be because of the infections. So infections are, there can be transplacental fetal infections, which may occur with microorganisms, and the fetal loss could be because of, for example, infection could be viral, parasital, bacterial, okay, or it could be spirochetes. So in viral, we know the examples could be rubella or cytomegalovirus virus. Parasites, we know toxoplasma, or it could be malarial parasite. Bacterial, we know which are the common bacteria which can cause abortion. So we say these can hardly cause abortion before 20 weeks because there is effective thickness of the placental barrier. So these are the factors which contribute due to infection in the female. Next are the maternal medical illnesses. The female herself is suffering from chronic illnesses due to which the female may undergo abortion. In that, we see one of the common examples could be cyanotic heart diseases, or the female may be suffering from hemoglobinopathies, which are associated with early miscarriages. Or sometimes the female may undergo premature rupture of the membranes, which may lead to inevitable type of abortion. Again, we are going to see in the further slides what is inevitable. So premature rupture of the membrane is nothing but we are talking about the amniotic membrane, which helps in sustaining the amniotic sac. So if the membrane get ruptured earlier, we say it is premature rupture of the membrane. So that could be because of the this is included in the maternal illnesses. Next could be thrombophilias, or the female may have protein C resistant factor, due to which again the female may undergo abortion. So these are some of the causes due to which the female may undergo abortion because of illness to herself. Next are the environmental factors, in which cigarette smoking, alcohol, due to which there is more of the CO2 provided to the female, and which is going to harm the fetus, and the female may undergo abortion. Next, exposure to the X-ray, which may be to about 10 radiant, which has a little risk, but if it is more, then it may cause abortion. Next, if the female is having any contraceptive agents, for example, IUCD, that is intrauterine contraceptive devices, if there is in the uterus, it increases the risk of abortion compared to the oral pills. Next, the drugs, chemicals, or noxious agents, which may be acetic gases, or it may be form of arsenic, lead, or it may be formaldehyde. These are the risk factors due to which the female may undergo abortion. In under miscellaneous, we say if the female is having an exposure to electromagnetic radiation in the form of video display terminals, which is called as VDTS. It does not increase the risk, but to some extent, it could be considered as one of the cause of abortion if she is repeatedly exposure to this for the long period of time. Here we say some of the chemicals which are the female are exposed. For example, if the females are using hair dyes, watching television for long period of time, and here we say the female can be allowed to go for the fly airways during the pregnancy. This is not going to cause abortion in the female. Now here, this is the most important thing. Many times the causes of abortion are unexplained. So we say it contributes about 40 to 60% of the abortion, which are unexplained. So in spite of, we have seen many numbers of abortion for many causes of abortion, immunological, environmental, maternal illness, uterocervical dysfunction. So in spite of these numerous factors, it is found that it is very difficult in majority of the cases to pinpoint the exact causes of miscarriage. So too often more than one factor may be present, or however the risk of abortion increases with increasing maternal age, which we see nowadays. Most of the female are getting married after the age of 30 or 35, and it is found that it is very difficult for the female to conceive. So about 20%, 22% of the pregnancies are detected by urinary pregnancy test. What we see is urinary, that is HPT test, which is nothing but human chorionic gonadotropin hormone, which is found to be in the pre-implantation phase, which may be found lost. And before the clinical diagnosis, we see that the female undergoes abortion. So this is very commonly found in the clinical practice. Now, common causes of miscarriage is, we say, in first trimester, genetic factors are found to be 50%. Next, endocrine disorders, immunological disorders, infection, and sometimes it is unexplained. But when we go in the second trimester abortion, now we know the first trimester lasts from the first week of pregnancy up till 12 weeks. And second trimester begins from the 13th week of the pregnancy up till 28 weeks. So that is the first 3 months is the first trimester. Second 3 months are nothing but the second trimester. So in second trimester, the causes could be anatomical abnormalities. It could be maternal, medical illnesses, and unexplained come in both the trimester, because many times it is undetected what could be the cause of the abortion. Now here we say what are the types of abortion. Abortion is being divided into two main groups, spontaneous and induced. If we go for spontaneous, which occurs on its own, or we say it is involuntary abortion, under that it could be isolated or it could be recurrent. Recurrent abortion is also called as habitual abortion. Under isolated, the subtypes are threatened abortion, inevitable abortion, incomplete abortion, complete abortion, missed abortion, and septic abortion. Under induced abortion is nothing but voluntary abortion. Under that, we see the most commonest is medical termination of pregnancy, which is usually called as MTP, and second is illegal. So these are the types of abortion which we should know. Under that, first we are going to discuss about the threatened abortion. Now, threatened abortion is a clinical entity where we see the abortion process has been started or it has been begun, but we say it has not progressed to a state from which recovery is impossible. That means the recovery is possible, because here the product of concepted which is being implanted has begun to separate from the decidual wall, that is the endometrium of an uterus, but the process of detachment or separation has not been completed. It has just begun. So if the female is coming to us immediately and if it is being managed, then the female can continue the pregnancy. That is why we say the recovery is possible in this case. So here, what will the clinical feature, how the female will present to us? There will be a pervaginal bleeding, which may be usually in a form of spotting, or very scanty bleeding will be there, which may be brownish to bright red in color. And pain usually may be absent or it may be painless. but or it may be very mild type of pain which may go to the back, or dull aching pain may be there in the lower abdomen. So pain appears usually following the hemorrhage. This is a very typical picture in case of threatened abortion. Now, as soon as the female reports to us, what are the investigations which are very important for us? So first we should go for a careful per-vaginal examination. Should be very gentle, because our PV examination can be considered as a trauma, indirect trauma to the product of conception, and threatened abortion can continue as an inevitable abortion. So when we go for a per-vaginal examination, it should be in a very gentle and soft manner. Per speculum examination here reveals that if there is a bleeding, it is escaping through the external os. That means here the bleeding is through the vagina or through the genital tract. Other parts of the vagina or other parts of the genital tract are not involved. This is just to rule out. Now, what are the investigations which are required? We can go for the blood test for testing the hemoglobin, hematocrit value, check the RH factor in the female, AB blood grouping should be done, and go for an immunological test for the pregnancy. But here it is found that it is not helpful because test remains positive for variable period of time even after the fetus is dead. So here the important thing is we can believe only on the sonography reports. Here, if we are finding that a gestational ring with a central echo is found, it indicates that the embryo is healthy and female can continue the pregnancy. Along with that, if the female is coming to us in around more than 10 weeks or 12 weeks, you can see even the pedal cardiac movements with 98%, and we can say the female can continue the pregnancy. So what is the treatment which should be given to this female? Most important thing is we have to advise the female to go for a complete bed rest for a few days until the bleeding stops, and we can give some pain relieving medicines to the female twice a day so that the pain can be feel better. So some evidence of the treatment with, or sometimes we can find that the female is given progesterone to improve the evidence of the treatment, so which will help to increase the T1 to T2. That is the T helper cells. Okay. So here the activities of the female are limited to at least 2 weeks, and she should be advised to avoid any type of heavy work. Coitus should be avoided, and very important is she should be asked to come to do the sonography after 3 or 4 weeks, so that we can see whether the progress of the pregnancy is in a positive manner or not. So falling in serum beta HCG or decrease in size of the fetus or the shape of the gestational sac is getting changed, it says that the female is not having a good progress. So that is why sonography is very important. Now, what is the prognosis in these cases? It is unpredictable because threatened miscarriage in 2/3 of the pregnancy may continue up to 28 weeks of pregnancy, but many times it may terminate as an inevitable or missed abortion. So if we say in 2/3 of the pregnancy it may continue, but there could be increased frequency of preterm labor, or the female may present to us in the form of placenta previa. Placenta previa is a condition where the placenta is implanted in the lower segment or near the cervix, or the female may have an IUGR, that is intrauterine growth restriction of the fetus, or we can find there could be fetal anomalies in that case. So these are the things which can be seen in the cases of threatened abortion if the pregnancy continues. Next type of abortion is the inevitable abortion, where we can say the chances of progress of the state where the continuation of pregnancy is impossible. Why we say it is impossible? Because the process of separation, which has begun in the case of threatened abortion, has continued, and the full gestational sac has been separated from the uterine wall. So here as it has been separated, it cannot be reverted back or it cannot get stuck again to the uterine wall. So here we can say the continuation of the pregnancy is impossible. So what will the clinical feature in this case? As just now I told you, the gestational sac has been separated from the uterine wall, so the amount of bleeding will be increased compared to threatened abortion. And the pain which will be there in the lower abdomen will be colicky in nature. It is going to increase in intensity and frequency also. And when you go for an per vaginal examination, you will find that the os will be dilated, and we can see the product of conception is trying to expel out, or it is coming out through the vagina. So in second trimester, it may start with a rupture of the membrane, or there can be an intermittent lower abdominal pain, which will be nothing but representing as similarly as a mini labor. Now, as we know, the product of conception has been completely separated. The line of management should be, we have to accelerate the process of expulsion, because it may take 2 days, it may take 3 days, it may take 15 days also. If it takes more longer, there could be chances of profuse bleeding in the female, and the female may decolorate it to any extent. So here, first line of management is, we want to accelerate the whole process of expulsion as soon as possible. And second is, we have to maintain a strict asepsis condition in the female, because as the os is dilated, there are chances of ascending the infection from the genital tract, from the external genital tract towards the uterine cavity. So these are the two important things we should take care of. So under the general measure, we can say excessive bleeding should be controlled by giving methargine to a female, because we know the os is being dilated, and we are finding that the size of the uterus is less than the corresponding week of gestation. For example, if the female is telling us that she is 16 weeks pregnant, but here we will find that the uterus will be around 12 or 10 weeks pregnant. The size of the uterus has been decreased because the product of conception along with the bleeding is expelling out, so the size of the uterus decreases. The blood loss has to be corrected by giving intravenous fluid to the female, or if you are finding the female is found to be in a very severe hypovolumic condition, we may have to go for giving blood transfusion to the female. Now, what is the active line of treatment? It depends on week of gestation, whether the female is coming to us in the first trimester or she is coming to us in the second trimester. First trimester means before 12 weeks. And if we say second trimester, it is after 12 weeks. So if she is coming to us in the first trimester, we can go for DNC, that is dilatation and curate, or we can go for dilatation and evacuation, that is we have to empty the uterine cavity, okay, by giving analgesics. It may be local, or we can go for a general anesthesia. Alternatively, if you are finding the evacuation process is not being complete, is not being helping us, then we can go for a curate, which will help in evacuating the whole uterine cavity. If a female is coming to us in the second trimester, uterine contraction can be accelerated by giving oxytocin drip to the female. It helps in expelling the product of conception along with the placenta, which is retained inside. Or if the placenta fails to expel out, we can remove it with the help of an ovum forceps. So here, if the placenta is not separated, we can go for digital separation of the placenta followed by evacuation of the uterus under general anesthesia. So these are the procedures which can be done in order to control the bleeding or in order to expel the product of conception. Next type of abortion is complete miscarriage. Now, complete miscarriage, the word itself says, or it describes that the whole product of conception has been expelled out in a mass. So whole, that is complete product of conception has been expelled out. So here we can say the whole mass, the complete fleshy mass has been expelled out through the vagina. So here the female will present to us that at present the female doesn't have any abdominal pain, but she had just few minutes before or few days before, there was a severe pain followed by the expulsion of the product of conception and now the pain has been subsided. This is a very peculiar clinical picture in case of complete abortion. And vaginal bleeding will be nearly absent, or it will be in the form of spotting or trace of bleeding will be there. Now, when we go for internal examination, we will find that the size of the uterus will not be corresponding to the history of amenorrhea. For example, if the female is giving an 16 weeks history, you will find that the uterus will be 8 weeks because the product of conception has been completely expelled out and the os is closed now. Bleeding will be found in traces or in the form of spotting. The fleshy mass is found to be expelled completely. And here, if the female is coming to us in the first trimester, we can go for a transvaginal sonography. We'll find that the uterine cavity will be empty, which will give us the clear picture, because transvaginal sonography will be giving us the clear picture through the cervix to see whether the uterine cavity is having a product of conception or it is completely empty. Now, the management is the uterine cavity is empty, so otherwise evacuation or dilatation, or we can say curate, should not be done. But if you are finding some product is there, still something is there, you can go for it. Otherwise, it is not required. But in case of Rh negative female, the female with an antibody should be protected by giving gamma globulin, that is 50 micrograms or 100 micrograms intramuscularly. In the cases, if the female is coming to us, should be given within 72 hours. This is for an Rh negative female, the female who is having an Rh incompatibility. So this anti-D is not required in the case if the female is coming to us before 12 weeks of pregnancy, because there is no instrumentation should be done. Next type of miscarriage is incomplete miscarriage. Now here incomplete, the word itself tells you some product has been expelled out, but still something is remaining inside. So here the entire product fails to expel out. Some part is left inside the uterine cavity. So we denote that it is incomplete type of miscarriage. It is the commonest type met in the hospital or in the female, and it leads to complications. So how the female present to us here? There is history of an expulsion of an fleshy mass per vagina with an continued abdominal pain, and there is persistent vaginal bleeding. Now here when we go for internal examination, we will find again the uterus will be smaller than the period of gestation, because some part of the fleshy mass has been expelled, but some is still there. And we will find that the cervix will be patulous, os will be open, you can even enter the tip of the finger, and the finger will be stained with the bleeding. So on examination, we'll find that the expelled mass is found incomplete, and sonography will reveal the whole picture that some part of the product of conception is still in the uterine cavity. So USG confirms the diagnosis. So whether the uterine cavity is completely empty or some product is still there. Now here in this cases, what could be the complications? Here the female may go into profuse bleeding. There could be chances of sepsis, or if it is not being managed, the female may undergo placental polyp. So what should be the line of management in case of incomplete abortion? It is found that in recent cases, the retained product of conception, which is called as ERP, should be done. It should be done by resuscitating before any active treatment is undertaken. So if the female is having an early abortion, dilatation and evacuation should be done under any local anesthesia or general anesthesia, and we have to evacuation of the uterus can be done. If the female is coming in the late abortion, uterus is evacuated under general anesthesia, and the product of conception is removed with the help of an ovum forceps, or we can use for a blunt curate. In late cases, DNC operation is to be done to remove the bits of the tissue which are left. And important is the left product should be sent for histopathological examination. This is very important because the female has arrived late to us for the management. Medical management of incomplete abortion may be done. Here, medically, this is the process we have to do in a surgical form. But when we go for a medical method, we can give misoprostol to a female transvaginally every hour, that is 20 microgram. Compared to surgical method, it is complications are more common in medical method. It takes times also. Now, next type of abortion is the missed abortion. The words say it was missed by the female when abortion has occurred. So it has been labeled that it is called as missed abortion. Now here what happens, the fetus is dead and retained inside the uterus for variable period of time. So it is called as missed abortion, early fetal demise, and missed abortion is also called as silent abortion. So usually missed abortion is being diagnosed in the second trimester because the fetus is dead in the first trimester itself, but it was not being recognized by the patient. So it is retained inside for more than 3 or 4 weeks, and then the female realizes that her signs and symptoms of pregnancy are regressing. Then she comes to a doctor. So what are the pathological changes which we see in the case of missed abortion is, here we find the cause of prolonged retention of the dead fetus in the uterus is not clear. But when we say it is beyond 12 weeks, the retained fetus becomes macerated, or we say it becomes munified, and the liquor amniotic fluid get absorbed. The placenta becomes pale, thin, it may be adherent, but if the female is coming before 12 weeks, the pathological process will be different. The ovum will be of less size, more or less completely surrounded by the chorionic villi, because we know before 12 weeks chorionic villi are there which are helping to form the placenta. But it is beyond 12 weeks, the chorionic villi have helped to form the placenta. So this is the difference when the female comes to us before 12 weeks or it is after the 12 weeks. What changes occur or what pathological changes are going to take place depending on the dead fetus has occurred during which week of pregnancy. So it is a pathological variant of missed abortion which is affecting the fetus before 12 weeks. Now there is small, if it is before 12 weeks, we will find there will be small repeated hemorrhages in the chorionic decidual space. Just now I told you chorionic villi which are helping in implantation. There will be repeated hemorrhages which will disrupt the villi from its attachment. So there will be a bleeding which will be slight, and it will not cause rupture of the decidual capsularis, which is encapsulating the product of conception. So the clotted blood with and contained ovum. So here the chorionic villi which are getting disrupted because of chorionic decidual hemorrhage will be, along with that product of conception, is going to form a blood mole, because it will be nothing but bloody appearance of a product of conception which is being termed as a blood mole. So by this time the ovum becomes dead and is either completely absorbed or remain as a rudimentary structure. Gradually the fluid portion surrounding the ovum will get absorbed and the wall become fleshy, and hence we will call it as a fleshy mole. So what are the clinical features which will be seen in the case of missed abortion? The female will have persistent brownish vaginal discharge. Next, just now I told you there will be subsiding of the pregnancy symptoms. Then the breast enlargement which was found in the first trimester will be retrogressing or regressing. The uterine size will be again cessation of the size of the uterus. The uterus size will be smaller. Absent fetal heart sound even with the help of a Doppler USG. Cervix will be found to be firm. Immunological test will become negative, and USG will show there is empty sac or absence of fetal heart rate, movement or motion. This confirms that the female has undergone missed type of abortion. Now, as the product of conception is retained inside for variable period of time, how long it has been retained inside, depending on the female will have complications. The complications of missed abortions are there could be chances of blood coagulation disorders which are less likely to occur in the cases of miscarriage. So how should we manage these cases? It can be medically or surgically managed depending on whether your uterus is less than 12 weeks. The expected management could be many women expel the conceptor spontaneously if it is small, that is less than 12 weeks. Or you can go for a misoprostol administration vaginally. If you are finding it aborts within 24 hours, well and good. If it doesn't abort, then repeat the procedure after 24 hours if needed. And we will find that within 48 hours, the product will be expelled out. So this is the medical line of treatment. In the surgical, you can go for suction and evacuation or dilatation and evacuation, which can be done when the medical process is failed. Here, the risk of damage to the uterine wall and hemorrhage during abortion, hemorrhage during the process of operation should be kept in mind, because as the product of conceptus is retained inside, the female has chances of undergoing DIC, that is disanimated intravascular coagulation. So before going for any surgical procedure, we should see that we should not damage the uterine wall, otherwise the female may go into profuse bleeding. If the uterus is more than 12 weeks, same principles can be adopted, but intrauterine fetal death are to be followed by. So we can go for induction of an process of abortion by the help of prostaglandin, which is more effective than oxytocin. So we can use an misoprostol 20 microgram tablet, which will be inserted in the posterior vaginal fornix every 4 hours. We can go for maximum 4 or 5 times with the help of oxytocin, which is going to help in accelerating the uterine contractions. So oxytocin can be used maximum up to 20 milligram in international unit, and you have to go for monitoring the process of uterine contraction. If it fails, the patient needs surgical evacuation if the medical management fails. So following the medical treatment, you have to go for USG to find whether the uterine cavity has been completely evacuated or not. Otherwise, you have to go for the process of evacuation of the retained product of conception, which with the help of the ovum forceps or with the help of an curate. Next procedure I told you just now, dilatation and evacuation can be done when the cervix becomes soft with the help of prostaglandin. Or if you want a slow process, you can use a laminar tent. Nowadays, we don't use this. We can go for we can dilate the cervix with the help of dilators. Hagas dilator is very commonly used to dilate the cervix. And then we can proceed for the process of dilatation and evacuation. So evacuation of the uterine cavity can be done very slowly so that the female should not go into the profuse bleeding condition. Next type of abortion is septic abortion. Now the word itself tells you it is because of the infection or sepsis. So any abortion which is associated with the clinical evidence of infection of the uterus is said to be a septic abortion. So what are the clinical criteria which may vary? Abortion can be considered as septic when there is rise of temperature, which may be at least more than 104 Fahrenheit for more than 24 hours. If the female is having offensive or purulent vaginal discharges, or if there is any evidence of pelvic infection, along with the lower abdominal pain or tenderness over the abdomen. Now, how much are the incidence of septic abortion? It is difficult to work out the overall incidence of septic abortion, but we are finding that 10% of the abortion requiring admission to the hospitals are septic, because majority abortion are associated with incomplete abortion, and we are finding that majority of the infections are occurring because of illegal induced abortion. Okay, this is very commonly being practiced in our country. So many of the females try to go for abortion by the people or by the physician who are unskilled by an illegal process, and which may lead to any type of infection. Now, what are the modes of infection which are commonly seen? We say the microorganisms involved in the sepsis are usually present in the vagina. We say it is one type of endogenous mode of infection. So microorganisms could be anaerobic or it could be aerobic. Under anaerobic, we know it may be bacteroids, it may be anaerobic streptococci, Clostridium. In aerobic, it may be E. coli, it may be Staphylococcus, it may be Pseudomonas, it may be a beta hemolytic Streptococcus. These are some of the aerobic bacteria which may be organisms which may cause infection. Or in many cases, it is found that it is mixed type of infection. Increased association with sepsis is unsafe, induced due to the fact that proper antiseptic or asepsis are not being taken. Evacuation process is being incompleted. And here, by doing this illegal process, we are going to injure the genital organs or adjacent organs to the uterus, which may be bowels or intestines. Now, what is the pathology behind the septic abortion? We find that 80% of the organisms are endogenous in origin. So infection is localized to the conceptus without any myometrial involvement. Okay, so here we find, as we know, the vagina is having borderline bacilli. So we say it is endogenous. So 80% of the cases are having an endogenous. So it is only limited to the uterine cavity, not even the myometrium is involved. But in about 15% of the infection, the product localized, it produces localized endometritis. 80%, in 80% we find it is only inside the conceptus, but in 15% it may cause infection to the local area, that is in the form of endometritis, surrounded by a protective leukocytic barrier, or it may spread to the myometrium, which may be parametric, it may be tubes, it may be ovaries, or it may go into the pelvic peritoneum. So 15% of the cases could be found to a parametric, and 5% can go into the generalized peritonitis. So depending on, and which may give rise to an endotoxic shock. So we are finding 80% are localized, 15% may go to the peripheral organs. For example, it may be tube, fallopian tube, ovaries, or it may be peritoneum, pelvic peritoneum only. And 5% may go to generalized peritoneum, which may lead to an endotoxic shock. So this is the pathological changes which may undergo in case of septic abortion. So what are the clinical features which may be present in the cases of septic abortion? Most important thing is, depending on the severity and extent of infection, the clinical picture may vary. Okay, so clinical picture, the female may look sick or she may be looking anxious or anxiety. The temperature may be more than 38 degrees centigrade. The female may present with chills and rigor. There may be persistent tachycardia, hypothermia, abdominal or chest pain, tachypnea may be there. She may have impaired mental state. Some of the female may present to us with diarrhea and vomiting. On examination, we can find there will be tenderness over the pelvic region, and there could be a purulent vaginal discharge with an boggy or tender uterus. So here, this could be the picture in case of septic abortion. Here, just now I said it depends on the site of infection and spread of infection. So if we grade the clinical findings of the female, in grade where the infection will be localized to the uterus, in grade 2 the infection spread to the peripheral organs, for example, fallopian tube, ovaries, or pelvic peritoneum. And in grade 3, it could be generalized peritonitis, or it may be endotoxic shock, or the female may come with jaundice or acute renal failure. So grade 1 is commonly associated with spontaneous abortion, and in grade 2 and grade 3 we say it could be because of induced abortion. Now, what are the investigations which are required in case of septic abortion? So routine investigation includes that the discharge which are from the vagina or from the cervix, we have to take a swab and we should go for an examination so that we can go which type of organism is involved in this infection. So we have to go for culturing it, okay, to find out the media of the dominant microorganism, to find out the sensitivity so that we can give which antibiotic should be given, we should go for a smear of gram stain. Okay, gram negative E. coli, pseudomonas, or gram positive could be staphylococcus, it may be streptococci. Next, we can go for a blood for hemoglobin estimation, blood grouping, RH typing, and CBC. We can go for urine analysis to see whether the kidneys are involved or the bladder is involved. Next, special investigations. We have to do the USG of the pelvis and abdomen to detect the intrauterine retained product of conception, whether the female has spread the infection in the form of pyometra or foreign body. It could be in the intrauterine, it could be intra-abdominal also, to see whether there is free fluid in the peritoneal cavity or in the pouch of Douglas, which may be because of the pelvic abscess. Next, we have to examine the blood, because here we have to send the swab for the culture to see, because the female is complaining of chills and rigor. Okay, because of this chill and rigor, she may be dehydrated. So we have to see for the serum electrolytes, C-reactive protein should be done, serum lactate should be done. Then to maintain the protocol of the endotoxic shock, we should go for serum lactate, which is greater than or equal to 4 millimole per liter, indicates tissue hypoperfusion. And very important is we have to go for coagulation profiles. Okay. We can even go for to do an X-ray of a female to in the suspected cases of abdominal injuries or bowel injuries. If the infection has spread to the other organs, we can go for a chest X-ray to rule out any pulmonary complications or lung infections or lung involvement. Now, what are the complications which can be seen? The complications could be immediate. For example, the female may go into hemorrhage related to abortion. She may undergo injury to the uterus. And if the infection has spread, the female may go into generalized peritonitis, which may reach to the uterine tube. It may lead to perforation of the uterus, or it may help in bursting of the micro abscesses which are present in the uterine wall, which may cause injury to the other organs of the abdomen. Next, the female may go into endotoxic shock. Female may go into acute renal failure. And last, the female may go into any lung infection, or it may go into acute respiratory diseases syndrome. Last, the female may go into thrombophlebitis, that is inflammation of the veins. So these are the important things which could be there present in the septic abortion. Remote complications which may occur after 6 months or 1 year. The female may go into chronic debility, chronic pelvic pain and backache. She may have dyspareunia. There are chances of ectopic pregnancy. Many of the female undergo secondary infertility. Nowadays, we say when the female goes for any process of DNC or DNA, infertility cases are becoming very common. Okay, so these infertility cases could be because of blockage of the tube. Fallopian tube are having chances of blockage. And very last may be emotional depressions. What are the preventive measures? So we have to boost up the family planning acceptance in order to curb the unwanted pregnancy, so that the female will not go into the process of any DNC or DNA. There will be no chances of tubal blockage. And we have to enforce legal abortion practices so that it will be unsafe. Educate the female, motivate the female, educate the what are the facilities which are available should be given to the patient so that they can get a maximum benefit. And whenever we are doing any procedure, we should do it under antiseptic or aseptic precaution should be taken so that the female will not undergo any type of infections. Hospitalize the female, then take the swab for the culture, and we have to go for overall assessment of the case, investigate the female so that the protocol can be outlined. So what should be the protocol of the management? First is to control the sepsis. Second is to remove the supportive therapy to bring back the female to the normal hemostatic and cellular metabolism, and to assess the response to the treatment. So here, depending on the type of infection, we have to give the medicines to the female, antibiotics to the female if she is in the grade 1 or grade 2, or we can say she is in the grade 3. So these are the allopathic medicines which should be given. Along with that, we have to clinical monitor the female, note the pulse of the female, respiration of the female, temperature of the female, urine output should be monitored. How is the progress of the pain, tenderness, mass in the lower abdomen, whether her CVP is greater than 8 or not. So these are the general things which has to be managed. So this is regarding if the female is in the 3rd grade, antibiotic should be given of the 3rd grade, supportive treatment should be given, crystalloid infusion should be done so that the female should be managed from the endotoxic shock. So other organs, perfusion should be seen, dysfunction should be carefully managed in ICU unit. Okay, next we can go for an active surgery. If you are finding there is an injury to the uterus, injury to the bowel, when the investigation X-ray or USG findings show that there is massive injuries to the important organs, we have to go for active surgeries. Okay, then we have to manage the antiseptic septic shock or oliguria responding to the conservative treatment. These are the important things which should be done. And important is laparotomy should be done by the experienced surgeon with a skilled anesthetist. Removal of the uterus can be done if the female is highly parous, and if highly parous, or if the female is primary female, irrespective of the parity, if you are finding it is safer for the female to save her life, you can go for removal of the uterus, or you can remove the annexes of the female according to the pathology on inspecting what is being found. If even when nothing is found, laparotomy should be done, or simple drainage of the pus should be more effective. So here, unsafe abortion. Unsafe abortion is nothing but termination of unwanted pregnancy by the person lacking the necessary skill, or we can say environment lacking the minimal standard. So that we say it is an unsafe abortion. So 90% of the unsafe abortions are carried on in our country. That is why we find that 30% of the female are undergoing maternal death during the pregnancy period. This is the chart of different types of abortion which I have just now described you. It is in short form. Next type of miscarriage is the recurrent miscarriage. The word itself tells you it is more than consecutive 3 or more times, which occur mostly beyond the 12 weeks or before the 20 weeks of pregnancy. So incidents are 1% in a reproductive age, and we find that 30% of the abortions are for the 3 consecutive losses. Physiology, I told you, it may be mostly in the mid-trimester because of the cervico-uterine factors. Next, 5% or 3 to 5% could be genetic. We say parental chromosomal abnormalities could be contributing for 25% of the abortion. Endocrine and metabolic causes could be because of poorly controlled diabetes, or there could be autoantibodies of the thyroid which may be causing abortion. Next, if there is an abortion in the first trimester, it could be because of luteal phase defect. It could be because of polycystic ovarian diseases, which could be cause of the missed trimester abortion in the female. Besides this, there could be elevated level of LH, which may be responsible, or hyperinsulinemia or hyperandrogenemia could be the causes. Last cause could be an infection to the genital tract, which may give rise to a transplacental fetal infection, and there could be risk of abortion in the female. Inherited thrombophilias could be the cause of abortion both in the early and late weeks of pregnancy because of intravascular, that is the spiral artery which is supplying the endometrium, which may cause intravillous thrombosis, and the female may go into abortion. Next cause could be protein C resistant, which is the most commonest causes abortion in the first trimester. Next factor, we can say there is deficiency of the protein C, S, and antithrombin, that is 3, which may cause abortion in the female. which are very, very less investigated, or we can say immune factor. Just now I told you. So first causes of abortion in the first trimester, I told you, it is inhibition of the trophoblastic proliferation, release of local inflammatory, that is the mediator cytokinins, artery and placental intravenous thrombosis, and decidual vasculopathy with fibroid necrosis could be the causes. Next, again, there could be natural cell killers which may cause abortion in the first trimester. Two group natural killers, no relation between the peripheral blood natural killers. So these are some of the causes of abortion. Next, there could be an parental human leukocyte antigen, that is called as HLA, which could be contributing for first trimester abortion, which is going to cause absence of maternal blocking or cytotoxic antibodies. Okay. Next, and we can say majority of the cases there is unexplained abortion. Now, what is the role of homeopathy in abortion? How can we save abortion in the female by giving our medicines? Here, before starting with homeopathic treatment, so complete abortion, we know there is no further treatment required, but constitutional remedy can be prescribed for better healing. In case of inhabitable, incomplete and missed abortion, uterus has to be evacuated. Then we can think of constitutional remedy may be required after the procedure. But in case of threatened abortion, homeopathy has a good scope because we know here there is chances of continuation of pregnancy. So homeopathic treatment along with supportive measures help the patient to recover completely. In cases of habitual abortion, judicious use of homeopathic remedy, maybe in the form of constitutional, anti-miasmatic, helps to deliver a healthy baby. So in order to give homeopathic remedy, we should take a proper history taking skill should be there. Observation helps in forming an acute totality. We should go for finding out the elements from triggering factor in the female, and then we have to prescribe a remedy to a female. Prescription can be based on the color of the bleeding, type of the pain, mental state of the female to select the appropriate homeopathic remedy. Next, how can you analyze the miasmatic things? Abortion can have a tubercular state, which may be psychosoric, or it may be pseudosoric, or it may be trimasmatic. Abortion, if it is due to infection, mostly if it is viral, then we can think about the tubercular background. If abortion is associated with clinical condition, like if the female is suffering from any clinical state or medical state, chronic nephritis or tubercular state, or it may be trimasmatic. If the abortion is from the congenital defect in the mother or in the fetus, we can think about trimasmatic or antisyphilitic medicine play an important role in known cases. If the abortion is because of fibroid, we can prescribe antipsychotic remedy to a female. If we are finding abortion is due to small size of the uterus, we can think of lumbar metallicum or as a syphilitic remedy to a female. Now here there are some of the rubrics, effective remedies which can be managed in the cases of abortion. For example, if the abortion occur in the early month, apis, vibram or colophyllum can be used. If it is in the later month, we say opium can help in the cases of abortion. Second month abortion, apis, calicarp, simicifuga, plumbum, picklecor will be helpful. If the abortion is found in third month, crocus, sabina, simicifuga, colophyllum, these are the remedies which can be used in the third month abortion. Similarly, if the abortion is between 5th to 7th month, the indicated remedy mentioned in the repertory is sepia. If the abortion is in the 8th month, they say we can help with the help of pulsatilla. If abortion is with anemia, we can go for sepia, ferrum, sulfur. We can go with the help of sickle core, carbovage or calicarp. If abortion is from anger, chamomilla can be prescribed. Abortion is from bad news, baptisia, gersemium will be helpful. If abortion is from cold, we can prescribe aconite to a female. If abortion is from cold and damp weather, we can think of Dulcamara. Abortion from cough, Calibrome or Rumex can be thought of. Abortion from emotion, Gelsemium, Helonius, Bacteria, opium, and chamomilla can be thought of. If abortion from excitement, Helonius and Gelsemium is given, the only remedies in the repertory. Abortion from exertion, Erigeron, Ruxtox, Bryonia, Helonius, and Millefolium are being prescribed. If there is abortion from fear, we can think of aconite. Abortion with fear of death, only remedy given in the repertory is coffea. If abortion is with fright, aconite, Gelsemium, ignitia, opium, and simicifuga are mentioned. If there is abortion from grief, ignitia can be thought of. Abortion from suppressed grief, ignitia and nitromute. Abortion from inertia of uterus, that is debilitated uterus, carbovage, colophyllum, Helonius, Sabina, Senecio, Simicifuga, Eustylago. These are the remedies which are given in the repertories. If there is abortion from injuries and trauma, we can think of arnica, pulsatilla, ruxtox, hemimalis, and ruta. If there is abortion from in a flabby woman, we can think of colophyllum, sickle core, and Eustylago. If abortion is from fever, baptisia can be the remedy. If abortion is from night watching, we can think again of baptisia. If abortion is from overheated, we can think of bryonia. Abortion from vexation, we can think of aconite and chamomilla. Abortion from weakness, the remedies given in the repertories are sepia, Helonius, colophyllum, china, Cilicia, sickle corn, nitric acid. If there is abortion from placenta previa, we can think of Naxomica, Sabina, sepia, Veritrum, vibram. Abortion with constant desire for urination, only remedy given in the repertory is Cantharis. Abortion from preeclampsia, the remedies could be Apis and Phosphorus. Abortion with pains predominating, the remedies are Actia racemosa, arnica, colophyllum, chamomilla, nux vomica, ruxtox, vibram opulus. With hemorrhage predominating, we can think of aconite, belladonna, china, crocus, hemimalis, ipecac, millefolium, sabina, trillium, eustylago. When there is discharge, black discharge, we can think of crocus, creosote, platina, pulsatilla, sickle core. When the discharges are black and coagulated, we can think of chamomilla, china, crocus, sabina, eustylago. If the discharges are scanty, colophyllum and nux vomica are prescribed. When the discharges are dark, offensive, and fetid, we can think of belladonna, chamomilla, crocus, sabina, sickle, eustylago. When the discharges are in gushous, bright red, only belladonna is been given in the repertory. When the discharges are passive, we can think of Alcaris, Holophyllum, china, and crocus, or Helonius, sickle core, eustylago. Discharges are worse from motion, then crocus, sabina can be given. In the cases of habitual abortion, if there is a disposition, we can think of Helonius. When the habitual abortion in uterine debilitative colophyllum can be given. If it is from impending gonorrhea patient, cannabis sativa can be thought of. If there is abortion from fall, shock, bruised feeling, arnica can be given. Shock abortion from great fright, we can think of opium. Abortion where there is flow, seizes, but retains with a great force, sees again and goes on, we can think of pulsatilla. When there is a precursory symptom of abortion, we can think of nux vomica. When the pain and motion in the uterine region as something is alive, we can think of crocus. Abortion from stimulant and drug or narcotics, we can think of belladonna, hipasulf, nux vomica. Abortion from rheumatism, Actia racemosa, colophyllum, ruxtox. Abortion from leucorrhea, calcarea carp, lycopodium. Abortion from lead poisoning, plumbum. Abortion from uterine inertia, Actia racemosa, china, colophyllum, pulsatilla, sabina, sickle core. Abortion from induration of the cervical uteri, we can think of aurum net, honium, sepia. Abortion from weight in uterine region, Altaris, abortion from anemia, calcarea cup, China, parum, kali cup, plumbum, abortion from uterine congestion, belladonna, cantharis, colophyllum, China, hepacil, nux vomica, abortion from gonorrhea, cannabis sativa, abortion in elderly primate, belladonna is being prescribed. The female who has tendency to abort, we can give the remedies, for example, colophyllum, simicifuga, plumbum, pulsatilla, sabina, sepia, sulfur, syphilinum. Abortion tendency in the second to third month, simicifuga, sabina, sickle, vibram. Tendency for threatened abortion, aconite, arnica, colophyllum, simicifuga, helonius, sabina, trillium pendulum, vibram opulus. Abortion with septicemia, we can think of pyrogen. Abortion in sequelae, Kalikap, Sabina, abortion with retains, succeedance, Steina, pyrogen, abortion from fatty degeneration of placenta, phosphorus, abortion from debility, we can think of China self, Helonius, sickle core, abortion from syphilitic taint, we can think of aurum, kali iode, abortion from blood, light, fluid, and painless millefolium, abortion from hemorrhage, which is persisting nitric acid, thalassi bursa. So this is how the abortion can be thought of. Many remedies, abortion with irregular pain irregular, feeble, tormenting, long, continued, passive backache. We can think of colophyllum, abortion from fatty degeneration of placenta, that is phosphorus. Thank you. This is from my side. Thank you, madam. I hope some important points has been received by the audience. Hello.
Yes, ma'am. Thank you so much for the in detail description, ma'am.
Yes.
Literally, it will be an enlightening for every participant also. And it was such a great pleasure for us to be you to be on the board, ma'am. Like you have explained each and every point in such a detailed way that it is very quite enlightening to learn also, ma'am, regarding the repertorial approach also.
Yes, I tried to explain everything from my side. I wanted to give maximum, but the time limit
Yes,
was,
yes, ma'am.
I still wanted to continue it. I wanted to complete the thing in a proper way, madam.
Yes,
Okay.
yes, ma'am. Yes, yes, ma'am.
Okay.
Thank you, ma'am. Thank you so much for the overwhelming session. And thank you all the participants for this for your overwhelming response. And we'll be soon back with the other guest speaker. So on Saturday. So thank you all. Thank you, ma'am.
Okay.
Thank you all the participants.
Thank you, ma'am.
Yes, yes, ma'am.
Okay.
Thank you, ma'am.
Thank you.